Hello, everyone, and welcome to Loop and Learn, formerly SoCal Loopers. We have a wonderful speaker tonight, Dr. Trang Ly with Insulet Corporation, the makers of Omnipod, which you all know, and we're real excited today. But as we always normally do to begin, we'll do our disclaimer, which is Loop is a do-it-yourself closed-loop algorithm, and while it may seem obvious, please consult your healthcare professional regarding your diabetes management. Remember that, and please understand that this project is highly experimental and is not FDA approved for therapy. There are thousands of people worldwide using it, but is still considered highly experimental. Therefore, you take full responsibility for building and running this system, and you do so at your own risk. Just wanted to talk about what's new with Loop and Learn. We've started a website, which is really pretty exciting and very active right now. It holds temporary information for new build problems, for scripts to help you do builds and maintenance, documentation that is not available anywhere else, and training videos and documents to help people like you with their DIY automatic pancreas system. It includes daily tips and a weekly quiz. We just had our first quiz yesterday. It's a lot of fun. Please just jump in, give it a try. You don't win anything, but it's a fun thing to just test your knowledge. There are scripts that you can just read through and easily upgrade software, and there are announcements, and we'll soon be able to have you sign up for notices on those announcements. This site is a supplement to, but not a replacement for, the documentation pages on Loop Docs, Loop Tips, the Facebook forums Looped, Loop and Learn, formerly SoCal Loopers, blog sites such as See My CGM, The Savvy Diabetic, or any other existing online content. So I want to just talk to you briefly about our speaker. I got a notice when I posted about Dr. Ly from Wes Nordgren, who is a significant founder in Night Scout Foundation. And he wrote to me, which he didn't have to do, which I thought was something we needed to share here. Trang Ly is by far one of the most knowledgeable people working towards bringing improved therapy and respite and relief to those suffering with type 1 diabetes. Since there are so many scenarios where a tubeless pump is a necessity, Omnipod 5, powered by Horizon, will be a solution that will be heavily sought after, especially those with little ones battling type 1 diabetes. This will be a great presentation, and if Wes says so, it is. Although Jeff Bezos of Amazon was saying the other day that we will have a man or a woman on Mars by 2026, we know that a true cure for type 1 diabetes will not happen in that time frame. So type 1 diabetes therapy has to become less cumbersome, less intrusive, and more intuitive. As Wes says, there is hope on the horizon, and he apologizes he couldn't resist the pun. So on to a little bit about Dr. Ly. Dr. Trang Ly is a leading expert in artificial pancreas and diabetes technologies and leads the Omnipod 5, what we think of as Horizon Automated Insulin Delivery System clinical program. Educated in Australia, formerly clinical assistant professor at Pediatric Endocrinology at Stanford University School of Medicine prior to joining Insulet Corporation 4 years ago. We will get to hear, hopefully, all about the Horizon system algorithm, as well as the timeline for when this and other products come down the pipeline. Perhaps she might even discuss Tidepool OmniLoop, inclusion of newer tech infusion systems, and Insulet's view of the critical need for expert data analysis systems for both healthcare providers and patients as well. As I mentioned, the poll that we have taken in the last week shows that 75% of the respondents who are using DIY Loop are on Omnipod, using pods. So this is real important to us, and we have a vested interest in knowing about what Insulet is doing and what the future plans are for pods and our ability to use them. So right now, thank you for listening. So honored to introduce you to Dr. Trang Ly.
And I'm going to share some information about our Horizon system, which is now called Omnipod 5. It has been renamed and will now be known as Omnipod 5. Now, we did that because there is a lot of brand equity in Omnipod, and we really wanted to retain that. So I'm going to share my screen. And thank you very much for the kind introduction. Okay, great. Thank you so much. I'll start here. So as Joanne mentioned, I am, actually, I'm not sure if this was clear, but I am Senior Vice President and Medical Director at Insulet Corporation, the makers of Omnipod. And my role here is to lead the clinical program. And that means I've been in charge of all clinical trials involving Omnipod 5 or the Horizon algorithm ever since we started clinical trials. And we've been doing that for almost 5 years now, since the very beginning when the algorithm was licensed by Insulet and then integrated within the system for so at Insulet, I lead the clinical program, also medical affairs, and also the human factors engineering as well. So our aim is to make sure that the products that we release for patients are safe and effective and can be used by a broad range of patients in a safe manner. We're making great progress with Omnipod 5. And we are hoping to release the product in the first half of 2020. So the Omnipod 5 automated insulin delivery system is our closed loop system, which is currently still under investigation, and it is in clinical studies right now. We just wrapped up what we call the pivotal study, which was tested in subjects age 6 to 70 years of age. And we're packaging all of that up and getting that ready for FDA submission. So we're in the midst of that. The system here that you see is the Omnipod, which has the algorithm embedded on the Omnipod itself, and then the Dexcom G6 sensor, which connects wirelessly to the pod, and then the controller, which has the Omnipod 5 app on it. So you use the Omnipod 5 app to activate and deactivate pods, to manage all your settings on it, but you don't need to keep the controller within close proximity to stay within closed loop, because you just really need the pod and the CGM which can be both be worn on body to stay connected to ensure the closed loop works. And so it is a hybrid closed loop system. You still will need to give boluses for breakfast, lunch, and dinner, but it will automatically adjust your insulin every 5 minutes, delivering a micro bolus depending on your current CGM and then your projected CGM. So as I mentioned, it's the pod itself is the same as the Dash pod and the Eros pods in terms of the size and footprint of the product. The difference being that it has the Bluetooth connectivity that Omnipod Dash has that allows it to connect directly to the Dexcom G6. The algorithm that has been known as the Horizon algorithm that's been tested in the last few years is built in within the pod. And as I mentioned, the PDM, which is our controller device, is used to start and stop automated mode, deliver boluses, and change settings. I think a key differentiator for our product is that it does have customizable glucose targets from 110 to 150. And that's been tested in our patients in our pre-pivotal study. So this was a small 2-week study that we did before it went into the larger pivotal study. And then it's also been tested through that larger study as well. Another key feature that we have is what we call HyperProtect, which is intended for people to use for times of elevated hypoglycemic risk, such as before exercise. So what it does there is it reduces the basal insulin delivery, as well as it changes the set point to 150. I'm going to cover some of the clinical study results that we've shared through this year. So the very first outpatient study results for Omnipod 5 were shared this year at ADA, which happened in June. And before that, all of our studies were conducted on our investigational system. And what that meant was that the algorithm was on a tablet that our patients had to carry with them. And then that was connected to the Eros PDM, which served as a Bluetooth RF converter. And so in that investigational system, the algorithm was on the tablet, and so there was just a lot of pieces to carry. And so we weren't able to do very long studies. Our studies at max were 5 days in duration. And so we were super excited because when we shared this data, it was the very first time that our patients were at home living their own lives, doing their own thing, and actually using our system. So super exciting for us. The design of this particular study was a 2-week period for 36 subjects, 18 of whom were aged between 14 and 17 years of age, and then 18 between 6 and 13.9 years of age. So that's our pediatric and our adult cohort. And during those 2 weeks, we asked our subjects to wear the system and use it at a particular set point or target glucose for at least 72 hours. So we, in total, had 9 days, 3 days at 130, 3 days at 140, and then 3 days at 150 to ensure that we were able to demonstrate that the system behaved safely at those levels. And then beyond those 9 days, there was a 5-day period of what we call the free choice period. So our patients could use and set whatever glucose target they wanted, and then that served the remainder of the 5-day period, so 2 weeks in total. And then our subjects were all invited to take part in our pivotal trial, and that is a 3-month study where we need to collect data over a 3-month period to make sure that the system behaves, that overall our patients are safe, and the system behaves safely and effectively over a longer period of time. And that is essentially the main data that FDA will look at to determine safety and effectiveness. And so these are the data from the 18 adult subjects where they used the system, and we collected their CGM during that phase. And then you can see here their time in range, time less than 70, and then time above 180, and then their mean glucose at those specific set points. And what you'll appreciate is that, these are a well-controlled group of adults, with a timing range at standard therapy. So that area in red is standard therapy. So this is what people were using at home. And the subjects who came into the study, many of these subjects were using Omnipod, but many of them were also using other pumps as well. And we also had a few MDI patients as well. So we did not require that people had to be using pumps before they entered into this trial. But overall, very excellent timing range for this adult cohort. What we also showed was so these subjects took part in the study in December, and we shared this data in June of this year. We wanted to also see, because everybody continued their participation in the pivotal trial, we also wanted to see how they did during the pivotal trial up until what we call the pause. So many of you may know that we had to pause our pivotal trial because of a software anomaly. This happened in about the March timeframe, and we took a few weeks to fix that software anomaly, and then everybody resumed the study in June, early June, and then we completed that study in September. So in June, we wanted to see, okay, we know that these 18 subjects continued their participation up until the pause. Let's pull that data and see what that shows. And what was very encouraging was to see that, when people use this for weeks at a time at home, in this particular group of subjects of 18, they achieved very good time in range of 73.8%. And then what's very impressive is that the hypoglycemia duration is low. So, they're coming in at an average of around 2.6. And then for this group of patients coming at 0.9% hypoglycemia, so very low rates of hypo. And then you can see that, the mean glucose doesn't change very much because this is a very well-controlled group of subjects. But overall, I was extremely impressed with the early data that we presented. The pediatrics gets a little harder, and as a pediatric endocrinologist, it's very important for me to see safety in this age group and even in younger children as well. So we have always focused our development efforts very prominently in this pediatric age group. So you can see here coming in, this is their standard therapy. So whatever they were on before, whether that was MDI or pumps, coming in at an average of 51% time in range. And then in the study, during their 5 days of free choice, you're up to almost 65%, and then over their 5 to 9 weeks of free choice, getting up to 70% time in range. So almost a 20% improvement there. And what I'm super pleased to see is, it wasn't at a cost of more hypoglycemia. So, if you've been following the space for a long time, it's one thing developing a product that gives insulin, but you cannot give so much insulin that you create more hypoglycemia, and then it becomes a safety concern for patients. So we are really pleased with these early data that shows, great time in range improvement, but also minimal hypoglycemia as well. But these results are only for a small group of subjects, only 36 in total, and we're still, wrapping up everything to get ready for final regulatory approval and then eventual release of that data, which we will publicly release early next year. So in terms of the user experience, we have asked our participants to complete a lot of questionnaires, and we look at all sorts of things. We look at sleep, we look at diabetes distress, hypoglycemia unawareness. But one thing we do look at closely is system usability, because for us, a key differentiator we believe for Omnipod is that our systems are simple and easy to use. And so, we don't want to create products that are so complex to use that, people stop using them, or that, regular people can't use it. So it's really important to us that things are simple and easy to use, and that people with very, very minimal training can pick up our products and use them easily. So in June, we presented the results of our systems usability scores, and these are self-reported, and it's only from the subset of participants who took part in the pre-pivotal study. But these early results show that, people do find it simple and easy to use, and just, compared to all the smartphone technology that is out there today, it's really great to see that people think that it's, kind of comparable to that. So in conclusion, the data that we have shown to date has shown that the system has performed safe and well in children and adults with type 1 diabetes in the 14-day period, which was our what we call our pre-pivotal study. And the other thing I didn't mention was that was collected last year during the holidays. And that is actually a time where traditionally, when we look back at the last 3 or 4 years of just Omnipod data that we can get from Gluco, that actually is a time where we see a deterioration of time in range of up to 3 to 4% time in range deterioration. So we're really pleased to see, this type of data, even though it was a time where we know that we're going to be challenged by meals and activity. During this short study, we saw very good connectivity and between the devices. So what we say in this study is that your devices should be within line of sight to ensure that the CGM is connected to the pod. And people were able to do that, fairly easily and remain with high percentage of time in automated mode. We didn't have any serious adverse events, and all of our subjects continued in their 3-month outpatient use of the system. Okay, I'm going to pause here and I'm going to take questions.
Easy first question, because this is your hometown. Any insights into timing for Omnipod being available in Australia?
Yeah, that's a great question. It's what we're doing right now is we are exploring Australia amongst many other countries, but we don't have a definite date of launch just yet.
Do you know what the holdup is on that? I'm sure they're going to ask. So,
there are various things. What I can share is that before we enter a country, we need to make sure that we can have a viable business, and we need to make sure that we can continue in that country for a long time. Which means, bringing our current product and future products into that market. And so we do a considerable amount of due diligence before we enter any market. Even though, some markets are more established than others, it's just a lot that we have to do to make sure that, we can have a sustainable business there for many years to come.
What you'll notice in our community, in the DIY community, is that we are probably horrifyingly proactive and possibly a little pushy on answers. So it's like, okay, and now we want it. So can we have it? So I apologize for that. A question from Doug Conmey. I hope I'm saying that correctly. How do you see Horizon differentiating itself from Tide Pool loop and or DIY loop?
Yeah, I'd say that the key difference is that with Omnipod 5 or Horizon, the algorithm is actually on the pod. So this will be the only system that is a tubeless on-body system with algorithm on the pod, where you don't have to, keep the PDM or smartphone with you to stay within closed loop control. So I'd say that is the key differentiator. And then I would say the other thing is, we have spent a lot of time developing the product for simplicity and ease of use. And so we have invested heavily in our human factors program to make sure that a broad range of people can pick this product up and use it safely. And also, we've invested significantly also in clinical assessment. So this product has been tested in subjects age down to age 2, in fact, Currently we have 80 subjects who are between the ages of 2 and 5.9 years of age who are using the product. And that's really important to me as a pediatric endocrinologist to make sure that our product is safe across the board, because it is different when you deliver 1 unit of insulin to a 3 or 4-year-old versus an adult. And so making sure that the sensitivity of glucose control, the gain of the system, all of that is suitable for all patients, requires a lot of clinical work and assessment to ensure that we have confidence in the product.
Okay, well, that makes a lot of sense. Let me ask you the next question, which has come up, which is the Omnipod 5 ready to switch immediately to Dexcom G7 as soon as it's available? And the follow-on is, what about working with Abbott Libre 3, and how about Eversense?
Yeah, so we are working with Dexcom and Abbott. We haven't publicly said when those compatibilities will be ready, but we are working very closely with Dexcom and Abbott. We, are just so pleased to be able to partner with such strong partners in CGM, and we're open to working with other partners as well. But those are two of publicly released partners of ours. The Omnipod 5 will be first coming out with G6, which is super exciting. And then we're also working on Libre right now as well.
How about Eversense? Are you seeing that coming back as a strong, viable alternative?
We've been in discussions with them in the past. I don't think we've publicly, made any discussions, but I will say, the diabetes community is pretty small, and, Dr. Frank Kaufman and I do connect regularly, but it's not a partnership that we've commented on publicly.
With G6 being the partnership that's ready to launch, can you, one, remind us, because audio cut out, of the intended launch date? And two, is there a plan already for how that's going to be prescribed and then received by users? Is this a double subscription that we have to get from our physicians, or is it a package subscription?
Yeah, great question. So in terms of launch date, it will be first half of 2021. We haven't been more specific than that. That's what we've said. And that's all I can say today. In terms of, it's a very good question, in fact, about the prescriptions. So they are two entirely separate products. So it's different to how, other companies have done it. But for us, it's two entirely separate products. The apps actually don't talk to one another. So they're two separate apps. So your Dexcom G6 app, you will use just like you use today. You start and stop your sensor that way. You manage all your calibrations, sensor errors, all of that through your G6 app on your phone. And then the Horizon app will be available, Omnipod 5 app will be available on either an Insulet provided controller or downloadable from your smartphone. And that Omnipod 5 app has a flow that is very similar to Dash, if you have seen it. But basically, you go through first time setup, you set up your time and date, and then your basal rates, and then your Bolus Calculator settings, and then you start a pod. And then you go to settings, and then you enter in the CGM transmitter ID. And that's what tells the PDM to tell the pod which transmitter to look for. And then that pod will speak directly to that transmitter, because, as you know, the Dexcom transmitter has 2 slots. So we'll take up 1 slot, and then the Dexcom app will take up the other slot. And then that's how the two talk to one another. So they are two very separate products, and we will not be managing any of the Dexcom side of things. That it will be two prescriptions, although we haven't publicly disclosed any of that, but that's most likely what that setup will be.
So let me make sure I clarify what I think I'm hearing. I would be able to run the Omnipod 5 on a PDM-like device or on my iPhone or an Android device?
As a first offering, it will be on selected Samsung models at the first release, but we are planning to add additional phone models on a very regular cadence. And yes, we are working on iOS, but we have not disclosed when that will be coming out publicly. But yes, that is the plan.
And then within the Omnipod 5 app that resides on whatever phone it runs on, will we see the Dexcom data streaming into that, or will we have to toggle back and forth between the apps?
Yeah, great question. So you can see the Dexcom number directly on the Omnipod 5 app. Similar to the pictures I showed you, so the Omnipod 5 app will have all the pod stuff, but also will show the Dexcom CGM value, and then also will show a graph with the CGM and also the insulin as well. So there will be a graph. Those are the major changes with the Omnipod 5 display.
I'm curious about the underlying algorithm and where it came from. We see, I just read that Eli Lilly is going to be using something from University of Virginia Type 0. Others are developing their own algorithms. Is it fair enough to ask where yours is developed and where the ongoing development comes from?
Yeah, so originally the algorithm came from UC Santa Barbara, from doctors E.L. DeSalle and Frank Doyle. Frank then became dean of the engineering school at Harvard. And then actually E.L. I think now works for Lilly now, and presumably on their closed loop program. So these researchers had a long history in the artificial pancreas space and had been one of the very first researchers to apply control theory to closed loop control. So that's where it came from. But I would say that it is very much the Insulet algorithm now. We really took that algorithm. It's one thing developing it in the academic world, but then taking that algorithm, making sure that it is safe for users of all ages, is a completely different ball game. So the commercial application of it has been done solely within Insulet, with a very talented team of algorithm researchers, people who have are well versed in this area, to make sure that the algorithm is safe and effective. And so we've been making tweaks all along. So every time we do a clinical study, we look at all the traces. I look at every insulin dose every 5 minutes, and we assess whether the algorithm has behaved safely or not, and we make changes along the way. So in the beginning, we weren't delivering enough after a meal. The algorithm was too constrained after a meal, and as a pediatric endocrinologist, I know that in the real world, that's just not going to work, because people, underestimate their carbs and they just actually don't bolus. So that is much more real world rather than being accurate with their carb counting. And so, making sure that the algorithm can work in that real world setting is really important. So we all of our clinical trials, we've been very deliberate about pushing it to its limits. So we do that by, making sure our adults are exercising, intensely, at least moderate intensity exercise. We make sure that they're having meals and not bolusing so that we can see, how they manage. They have had high fat meals, pizzas for dinner. And then we let the algorithm run and see how it goes. And then, I can't stress enough, how important it is to test it in little kids and make sure that it's safe in that age group. But also, we want to make sure that it works in the adults who are on, 100 units a day with a lot of insulin resistance. We want to make sure it works well in that age group as well. So we just learned so much from our participants and subjects that, I feel really good and confident about what we're going to be bringing to market.
Is the algorithm a learning algorithm?
It's learning in a sense that it adapts based upon the total daily insulin that is delivered. So if you start off and you're 20 units a day, and then you grow and you come out of honeymoon and you start to get 30 units a day, the algorithm will adapt over time. So it adapts at every pod change. So that's when it kind of accumulates all the data, does a bit of a reevaluation, and then it kind of does that setting at every pod change.
What you just said actually points to a question that was asked much later, but is there a minimum insulin requirement or a minimum size requirement that will be required for the system? And I think this question was specifically directed towards babies or very young children.
Yeah, what the eventual indication will depend on our discussions with FDA. But, what I can say is that the system itself doesn't require you to say what your minimum requirements are. When we've done studies, the lowest requirement has been down to a total daily dose of about 9 units a day. So, they are pretty low doses, but what the final labeling will say will depend on our discussions with FDA. But we've never wanted a minimum requirement. We think, okay, if you need insulin and you need to be on Omnipod, then you're just better off on a closed loop system, no matter how much insulin, whether that's 5 units or 10 units. So that's our thinking all along. But, FDA might not agree, and there might be a minimum put in.
Yeah, so it's kind of interesting because right now, basically, with Omnipod, you pretty much have to be able to use less than 0.05 units an hour of basal insulin, or else you really can't go on it unless you dilute it.
Right. And that is, a very low requirement. And I would say, as a pediatric endocrinologist, I think that's a pretty reasonable amount, because that is actually really, really low. And if you're needing less than that, then, it may just be that you're really, really early and you may not be ready for this.
Right. You might be still honeymooning or something like that. Yeah.
I mean, as just out of interest, there's this condition I'm sure you're aware of that's called congenital hyperinsulinism, where babies are born, with this terribly disabling condition of hypoglycemia. And sometimes the therapy for it is a pancreatectomy, or a near total pancreatectomy. And literally the surgeon goes in and cuts most of it out, and they hope that the bit that they leave is enough to sustain life, without diabetes. And sometimes they get it just right, and sometimes they take off a little too much pancreatic tissue, and then the babies end up with diabetes. which in fact a lot of families say is actually easier to manage than the terribly disabling hypoglycemia that they get. Anyway, long story short, there's at least a handful of patients out there who are, under 6 months of age who use the product just to infuse, a little bit of insulin as a result of this rare condition.
We have some use, questions from Facebook. The first being, are you going to be able to set your own target below 100?
You cannot. So for Omnipod 5, the lowest target glucose will be 110, and then between 110 and 150 in 10 milligram per deciliter increments. But I will say that we're still, when I think Joanne asked me earlier, what are we doing for kind of next generation and future? It is something that we are looking at very, very closely as to whether it would be safe to go to, 100. I think that, it's important to realize that just because a system is set at a certain target doesn't mean that you achieve that mean glucose of 100. Just want to open that. Yes, exactly, right. And then also, not all systems are the same, right? So you can set the same target glucose in different systems, but if you've got a system that is terribly constrained, right, and not responsive, you're going to get different glucose results to a system that is highly responsive and can deliver, mini micro boluses every 5 minutes and get you to a certain target. So we feel really confident about our 110, but you're right. It doesn't mean that it wouldn't be safe for certain people to go to 100, and we'll be exploring that for future systems and future customization. But right now, the plan is for Omnipod 5 that it will be just 110 to 150.
Thank you for Jeremy's crying. Jeremy Lucas is crying on Facebook. A second usage question from Gail. Can you speak a little bit more to how exercise works on Omni 5? Is it going to be like a temp basal situation, raised blood glucose targets? The loopers have plenty of ways of dealing with exercise that we all try and differently manipulate.
Yes, and I would say for sure there is no one size fits all. The people in our study, so I'll tell you, so the feature for those of you who missed it in the beginning is it's called HyperProtect, and it adjusts the target glucose to 150, but it also reduces the basal insulin as well. So when you start that, you're going to get less insulin, and you will, ideally have less insulin on board before you start exercise. So that's what the intention was. And we developed it after doing a ton of exercise studies to decide on this final configuration. So it's not going to work for everybody because we know diabetes is just not like that. But we, feel confident that it works well in people if you can set it early enough. And the other thing I'll say is that, in some adults, I've heard from the study, they have not necessarily used it, but they'll, go have a banana and then go for a run. And then the algorithm, just the regular algorithm at their regular target, does a good job of keeping them in range.
Okay, great. Let's see.
Okay, so the question is, once an algorithm is approved by the FDA and it ships, are changes to the algorithm, do they require new approvals from the FDA? And how often would you expect updates to come to the algorithm?
Yeah, I would say that it would depend on what the change is. And, if it's going to change the amount of insulin that you get, then, this is serious stuff we're talking about here, then, that really affects glucose control and the safety parameters of the controller. So that would require additional clinical trials to demonstrate safety and efficacy. There are some things you can do in silico, and there might, there could be some changes that we might decide to make because we have a lot more data now, and we learn as we go. But I don't think that we would, big changes that affect glucose control. We'd need to do clinical studies, and you'd hear about it, and it will probably come as a product release. But the idea, what we've been moving towards in the last few years is going from is moving into the pharmacy channel, where you can get your pods through pharmacy, and that is important for us, because it means that if updates do come up, that our patients can access that quickly, and not be locked down into a 4-year contract. So I will say that we have, even though I'm not going to be able to answer questions about how we handle upgrades and things like that in terms of your insurance right now, that will come later as we figure it all out. I will say that we have, one of the main benefits of moving into pharmacy is so that our patients can get access to the latest technology quickly.
I actually got an interesting algorithm question that someone sent me. I think she intended to send it to the group, but it got sent to me. But can we adjust the adaptive learning if we know that the last 3 days won't represent the coming 3 days? So the examples given in this were period hormones, steroid shots, sickness, etc.
Yeah, not with the system that we're planning to release. So there isn't a way to adjust that. I will say that it's not based just on the last pod. It looks at a longer period of time for the adaptivity. So if you just happen to run a little higher and require a lot more insulin in the last 3 days, it will have a little bit of effect. But unless that increase is sustained over several pods, you're not going to see that change, any large change straight away.
Does the algorithm help detect bad pods or dead spots too?
Yeah, so we we have improved our occlusion algorithm. I don't know if you're all aware of this, but we modified the actual cannula by making some changes to the cannula design. And this happened probably about 12 to 18 months ago now. And so that has actually dramatically reduced the rates of false occlusion in the product. So this happens with all Omnipod products.
Yeah, it's like side holes or something now, right?
That's right.
Yeah.
Yeah. So
for anyone just listening in, we did do a presentation with Capillary Biomedical, Mark Estes. Go back and watch that. We're super interested in infusion tech. Can you talk a little bit more about what that change was? I didn't know any of this.
Yeah, it's basically Glenn was right. There are side holes. So what we did is we drilled holes, 2 holes, one right through the cannula, 1 hole on one side, 1 hole on the other. And what we demonstrated on some internal data that we were able to generate was that reduced the rate of false occlusions down to about 80% reduction. So, what it meant was that the insulin diffusion in the sub-Q tissue was doing a better job of that. So we're super pleased to be able to bring that out, make that more accessible for more people.
I think Dr. Buckingham or Havorka mentioned that. And I think all of us, when we pulled our next pods, were examining them, looking for
Exactly.
Are we able to see? I mean, we're just got curious. Can we see them?
Yeah, it's really hard to see. the first time I saw it, it's very hard to see with the naked eye. Someone gave me two and they're like, which one has it? And I was like, that one. They're like, they both have it, Trang. So it's like hard to pick up with the naked eye. So
got to get our microscopes out, Joanne. If we can go back to Facebook for a second and speak to something that is near and dear to everyone in this chat's heart, can you let us know what production on Eros pods, the future of it, looks like?
We can't say, I don't think we have said anything about end of life dates publicly. And I believe that there are certain requirements that we would have to let you know well in advance of if that were to occur. So, I believe it's at around 12 months of notification before we end of life Eros pods. So that's what I can say.
Have you seen increased adoption of pods because of do-it-yourself tech? I mean, I, for one, can speak to the fact that I am now an Insulet customer because of do-it-yourself Loop. It totally improved me.
I would say that our business has grown in general, not just from DIY Loop, but just in general across the board from in both US and globally as well. And I think that has happened for a lot of reasons. We have just grown a lot as a company. We're able to do a lot more as well. I think access has a lot of effect on that as well. We are so grateful to be able to bring pods to whoever uses them, but I can't personally endorse Loop because it is not an FDA approved device. So I just can't say that, but I am grateful that, we're able to make pods that are beneficial in your lives.
I have an interesting question that isn't directly about closed loop, but it comes up every year at this time, and it has to do with static discharge. And I talked to Eamon Malik a couple of years ago because everyone that I was talking to swore up and down that if you used some duct tape on the back of a pod, it would reduce static discharge. And he laughed pretty hard. And yet that has come up again this year. And it's when things get warmer out and people wearing wools and there's static and it zaps the pod. Can you address that at all? And how do we improve that?
I love this question, actually. So thank you for asking. So yes, we used to have an issue, or ESD, electrostatic discharge, where the static would cause the electrical circuit to short, basically. And so the pod, as it is designed, when it detects anything unusual or abnormal, it should go into a fault detection mode. So then pod alarm, and so that's all supposed to happen. It's just highly inconvenient for people, for our users, because it goes off, when they're about to go skiing and things like that. So it's not ideal. So we actually, again, also about 18 months ago, made a specific change to the circuit board where we basically rerouted the ESD to a part of the board that we don't use to get rid of this problem. And it's markedly improved the false alarms that we're getting with ESD. So it should be much better in the field. It's not going to go away completely, but the numbers have dramatically dropped down. So if you're a diehard duct tape user, I would just say maybe give it a rest and see whether you need it. It may have improved sufficiently that you don't need it.
I also hear dryer sheets. and they're supposed to rub it on there like for good luck. But I hear the kids, when they slide down a slide, seem to pick up a charge that's zaps. And I don't know if that's pod related or just simply the dryness in the air, and there's a static discharge all over the place.
Another reason not to own a cat, because they always generate static.
It definitely was an issue, in the last, few years, and it was one of the number one questions our product trainers used to get, in fact, and it was a pretty high rate of complaints that we would get from people. But it has markedly improved, and it's because we made a design change to the circuit board.
It's an interesting question about, so thank you for that, because it comes up, and it's this time of year every year. Will there be an ability to enter finger stick readings in the PDM as it is now during the sensor warm up or when sensor readings are off? Does that still exist?
Yes. So you absolutely can enter a BG. I will say it's a nice segue to be able to say that our Bolus Calculator uses not just the CGM value, but also the trend value as well. So if you're, 200 and skyrocketing high, you will actually get up to 30% more insulin than if it was reading just a BG of 200. Does that make sense? And then same down the other way. So if you were 200 and, dropping very, very fast, double arrows down, then you, depending on how much insulin on board you have, et cetera, the Bolus Calculator will make an appropriate recommendation as well. So our Bolus Calculator is slightly different to others, but yes, you will always have the ability to always enter in your BG instead of always having to have your CGM. Obviously, you won't be able to be in, the system won't be functioning in delivering an insulin that is reflective of your CGM if you don't have one connected. So it will deliver essentially a basal insulin during that time when you don't have a CGM.
So we're jumping around a lot, but the questions are all over the place. In setting up Omnipod 5, do you enter your standard settings? In Loop, we do that as well. We spoke with Ed Damiano last week, and we love the concept to just put your weight in. But is it the standard settings, and is there a system in place at Insulet to help people change their settings? Because we notice that when you go on Loop, your settings do change from what you had been using before a looping system.
Yeah, this is actually a very important question to really denote how our algorithm is different from others. So to answer the first part, yes, you do set it up as you set up any pump, and setting up Eros or Dash, as you would if you were using it as a standalone pump. So you enter in your basal rates and insulin to carb ratios, and it actually uses the target glucose that you would today set in your Bolus Calculator as the target glucose for the controller or the algorithm. So what the algorithm does as you go through onboarding with that very first pod, it uses the basal rates that you enter as a starting point. But as the system accumulates more information and more history, more actual insulin history of what you actually got, it will adapt based upon the TDI. And, after about a week or so, or maybe a couple of weeks of using it, it actually does not rely at all on your basal insulin. So unlike with Loop, where you make adjustments to your basal and it affects your glucose control, in Omnipod 5, it actually doesn't have any effect beyond that very first pod. It relies mostly on TDI.
And then duration of insulin action, do you set that as well, or does it also go once you have the initial setting, it takes off and chooses?
So the core algorithm uses our proprietary duration of insulin action that we have set for the controller. And then the user can set their own DIA, and it will affect the timing and appearance of insulin on board that they see from all their manual corrections. So, you know, if you're someone who has, who likes to correct a lot frequently and, you know, and use tiny amounts of insulin, so you like to set your DIA pretty short, you can still do that and it will still behave in a way that you're familiar with. It's just that the core algorithm is not so affected by that. It's more robust.
Okay, so is there an ability, so if I know I'm going to have a Medrol pack 5 days of cortisone, I can set an override or it will pick it up?
What do you mean overrider?
Override, an increase in basal and bolus numbers because there's cortisone in the system.
Yeah, so you can set your correction factor however you want during that time. If you set it, you know, of the number, you'll get that insulin. So the Bolus Calculator, you have full control of your correction factor and then also, you know, the target down to a minimum of 110. So if you were about to do that, then that's what I would recommend that you do is, you know, change your correction factor. Your DIA, you know, wouldn't normally change in that scenario, but it could be something that you adjusted if you wanted to.
Okay, so we're seeing some interesting questions having to do with our lives are variable. So, okay, we have a big party to go to, so we all go on low carb, so we lose weight, so we fit into our clothing, and then go to the party, and then we eat a lot, and then we keep eating for days because it's a holiday. How do we let the pod know this is a major change, or what does it take time to catch up?
Yeah, I think in that instance, the main control or the main input that you would provide to the system would be the amount of boluses that you're giving. And, you know, you do that through just mainly the bolusing. And then the algorithm will catch up. And it's also pretty robust. You know, when we looked at how to really optimize, you know, how to really optimize a controller for lots of people, we thought really hard and we looked at the data very closely. And, you know, your basal rate could be up to 300%. So essentially, you know, your total insulin requirements could be, you know, 3 times off. And the algorithm would still be able to kind of figure it out. So there's enough kind of room in the system to give you more when you need it. But we still need you to bolus for food and give corrections if you're going to, you know, eat double what you're used to doing.
So I assume then we don't mess around with insulin sensitivity as well. We give it an initial best guesstimate and then it starts to adapt as well.
So so in our system, it just uses whatever you have as for the correction boluses that you deliver. But the algorithm corrections, I would say, is based upon total daily insulin rather than what you enter.
It's a very different way of looking at it. You have to step back and say, it's not our way, it's your way.
Different to Loop, it's different to Control IQ, it's different to Medtronic, which I know is terribly confusing. And, you know, one of the reasons why we made it sort of that way is because we want the system to adapt and grow with the user and not people we don't want to have to subject people to tweaking their settings all the time. So it is based upon total daily insulin because that is a very robust measure. Look, if you needed 40 units a day, then we know it's pretty safe to give you, 2 to 4 units without you tanking, so it's a very robust measure. Whereas, what if people enter in weight incorrectly when, or their basal rates incorrectly? We know that happens. Sometimes people forget about decimal points and, is it 0.05 or is it 0.5 or is it 5 units an hour? People do get those things wrong. We want the algorithm to be safe. So there are trade-offs that you can make, but what we thought about was, okay, we want this to be robust. We want to alleviate burden for our users. We don't want to say, okay, you've got to look at it every week and make changes. That's not what we want. We want something that you just put on and it will work, most of the time. And you have to bolus, but it will work.
It's interesting because part of our concern has been who is going to do the data analysis of all the data that comes out and have the expertise or the expert system in their brain to then get the information to the user, and which doctor's office is going to do that. So this does that. Instead of needing constant data analysis, it does data analysis.
That's right. It is something we have thought heavily about because, even though I am an endocrinologist, I know that we don't want to rely on our doctors and our CDs to have to hold our hands through this whole process forever, right? It's not just the first 6 months, it's forever we're talking about here. So we developed it primarily for patients in mind and reducing burden for them, and something that would be robust so that, it wouldn't be so subject to whatever correction factor you put in. But still have that flexibility so that you don't have to game the system by entering false carbs, because we know that happens, right? Before Insulet, I worked at Stanford, as Joanne said, and I worked with Bruce Buckingham in his group for 4 years. I've actually been doing this. So one of my patients from Australia, just his mum sent me a message the other week, and we looked back at his dates and times, and I think it was 2008 when I did the first automated insulin delivery closed loop system study back in Australia, and from there I went to Stanford and we did a bunch of clinical trials there. Bruce and I actually did some of the very first studies in diabetes camp settings where, we tested the preliminary versions of the 670G. And, it was quite different to what ended up being released. The 670G system, was the first of its kind. It was the first commercial system. So it, does have its limitations. But it's important, what we've seen from this space and we've all seen and bear witness to is that, for these systems to be successful, people have to wear them. You can't annoy them with alarms and false alarms, and you can't, you just can't annoy your patients. So it has to be sustainable and it has to work, and people have to trust the system, and you can't aggravate them. So we have designed the product with minimal alarms. We've tried to reduce the alarms that Omnipod itself can generate because of the system. We are a different system. It's a tubeless system. It has to have some way of detecting faults. And then we're partnered with a great sensor that you don't have to calibrate. And so that is, one of the benefits of that system.
So the interesting question is, how do we get to download our basal rates, suppose we need to switch systems or our pod fails, we don't have a new one and we're on shots for a couple hours. How do we get reports out? Does it include everything like notes you might put in, I did exercise here, I was in the jacuzzi here, or and your blood sugar readings as well? Is there a report generator that's included?
Yeah, so you may not know, because it sounds like many people use Eros in this group, but with Dash, we do have cloud-to-cloud connectivity with Gluco. So data from the PDM goes directly to the Gluco cloud without the person actually having to upload the device. It happens via Wi-Fi. And then Gluco has that information in near real time. It does it at every midnight. And so, they can go to their doctor's office and they'll be able to pull their Gluco account up and that data will be there. So we already have that functionality today. We have that cloud connectivity for various reasons. That's one of them, but also we have, Omnipod View app where parents can download the app and be able to see, the last bolus, how much IOB, how long the pods last, some key information there as well, and on the Omnipod View app. So we have that functionality of Insulet Cloud talking to other data management systems as well. So we plan to still have that capability when we launch Omnipod 5, to be able to have the View app and then also be able to have cloud to cloud with Gluco so that you can see all that information. And then there's the old fashioned way of just making sure that you have all your settings written down somewhere. So in case, a reset does happen. And I will say that, from time to time, it is important to keep your basal rate settings updated to what is appropriate for you. And, physicians will be able to tell from the system, approximately what that range would be. Just like we kind of do today when we put someone on insulin, it's all a bit of a guesstimate.
We didn't hear that, but yes, we did. So we understand that completely. Is Gluco, does that run real-time data, or is it more like Tidepool?
So if you logged in and you're a Dash user, data would be available at midnight, like last night. So it would just be not currently. So it's not quite real-time.
Okay.
But it is very updated, and it's for the purpose of sharing it with your HCP.
Okay, a lot of people in this community, probably most of them, use Night Scout, which is real time with historical reports that we can pull. And you could.
And there is a question speaking to that, right? If we can cross language between manufacturers here, and because you're pediatric endo, is there a follow option on Omni 5 for parents, right? One of the most important parts in the community of us using Night Scout is that parents can see all of the temps that have been changed, all of the boluses that have been delivered, right alongside that glucose number. So how do parents get the insight of what Omni 5 algorithm is actually bolusing their children for? Yeah,
we will see that with the View app, which is our synonymous with the Follow app, with the Dexcom Follow app. So we will be able to provide that. I will say, and at the risk of being shot down, I will say that, we really want Omnipod 5 to relieve some of the burden that you have. And I hope that you won't be up checking every bolus and basal rate change that your child is having. And that hopefully it relieves some of that stress that comes when you have a child with type 1 diabetes. and so it is a bit of a balance, but we, the other thing is, this is why we do clinical trials. Knowing that, in our clinical trials, there was no follow-up available yet. So the only thing they were following was their Dexcom. And so, these things are extras which we will provide, but the clinical trial did not have that. It was just really the system that they were testing.
Interesting question, because that comes up all the time, is how does Omnipod 5 handle fat and protein in conversion to carb numbers, or does it just absorb that information?
Yeah, we don't specifically take in fat and protein information. We really just know about the carbs. Yeah, that's it. So as a first gen system, we rely just on the carbohydrates.
How does that work with someone on a keto diet where there's mostly protein?
Yeah, so so we did have people like that in the trial, and the I can't really talk about the results, but that'll be a good question to ask when the study results come out, and we'll be able to look at that. I think that the core algorithm is pretty robust, so that even if your total daily insulin is mainly reliant on kind of basal adjustments, it still is pretty robust with that.
Okay, a couple of
this
questions.
This is a real like insider sneak peek we're getting.
Someone asked whether there are reports. I'm trying to look for his message. Matthew Levine asked if there are reports published where he can take a look at some of the published data that you have put out. And then the question also is, will we be able to see the learned personal parameters?
Yeah, that's a great question. First of all, the easy one is, yes, you can go to pubmed.com and Google Omnipod and my last name, and all of our papers will come up. So, there's like 4 or 5 papers at least, or if not more. There's probably at least 6 papers kind of documenting our progression throughout. It doesn't really talk about our algorithm changes along the way, because those are kind of proprietary, but it does show the design of the studies where we tested and challenged the algorithm to make sure that it was safe. Okay, back to the other question about parameters. So the insulin to carb ratio and the correction factor is really the main things that you would change using the system. So you can see that from looking back at the data and seeing what your glucose profile looks like after the corrections. But those really are the main settings that you might want to adjust while you're using the system. And we did find that, like with all AID systems, when you go from standalone pumping to an automated system, you often have to set a tighter insulin to carb ratio because you generally have less insulin on board in your actual body, coming into meal. So you have to set that a little tighter, and that's pretty common. We found that as well. So those are the 2 main settings. Otherwise, you don't really change anything else. So if you were running high, I'd say look at your target glucose and then look at your insulin to carb ratio and correction factor if you're actually, relying on those to correct. And then, if you're running low, again, looking at your correction factor, insulin to carb ratio, and then your target glucose with that as well. And so if I wasn't obvious, you can set different target glucose through different times of day. So if you're a person who likes to exercise a lot in the afternoon or late afternoon, you can set a slightly higher target glucose around that time. And if you're a parent who worries about hypoglycemia and you don't want to set it at 110 and you want to set it at 130, that's totally fine too. So you can do that. You can set up a target glucose profile just like you set up a basal rate profile.
Okay, so the question bounces back. Can we use an insulin to carbs ratio and correction factor to intentionally run lower than the 110 that's preset, or will it automatically fix it?
I'd say I would say that the system will always review the insulin on board, and it will adjust depending on the insulin on board. And it makes that calculation based upon the total daily insulin. So if you're relying on that solely, you might cause a lot of crashing in the system and the algorithm just ending up suspending a lot in between that time, if that makes sense, right? Because if you just give a lot of boluses, it's just going to suspend because it thinks that you're just giving way too much insulin. So yeah, I wouldn't recommend that. Yeah.
We're a community of tweakers, and we aim for a very, very, sorry for that, Cass, a very high level of good numbers. So we've been going a long time and I really appreciate the time. I'm going to ask you the question that I've been asking some of our speakers. Rehan Lal spoke with us, and I've gone back and forth with him about questions of time and range, and also Dr. Ann Peters. And I get different answers because everyone has different opinions. How important is what time and range that you like best for adults and then for kids? And the other question is, if you improve your time and range, does that help you dodge the bullet of complications, or are they unrelated?
Yeah, I think time and range is very much related to A1C, and we know that A1C is related to complications. I do think that the consensus statements and recommendations of 70% time and range corresponds to an A1C level, obviously without a lot of hypoglycemia, does correspond to an A1C level where marked improvements beyond that don't markedly change the risk profile of complications. So I think 70% is very reasonable, and certainly, again, at the risk of getting shut down by this group, I do think that it a lot of people can achieve that, and in the pediatric age group, I think that is a great goal, but I do think that the recommendations, even the international guidelines for pediatrics, are in fact say, even 60% is an excellent timing range to be aiming for. So I think these are really great numbers to be aiming for. And I do get very anxious when people start focusing on like 80% timing range or higher and say like that is like totally easy to get. Like I'm like, you just don't understand diabetes, because that is very hard to achieve on a large population-based group of people, and for them to like lead normal lives where they're not obsessing about their diabetes. So I think, 60 for kids and 70 for adults is a very reasonable goal that is nicely balanced with, healthy living and people just getting on with their lives.
We're going to have to put a lot of these DIY people on life support after you say 70%, because we do aim for more, because we have the tools, and would love to know that we could use your device and come closer to what we had before with an easier access.
Yeah, absolutely. And that's I would just say that they are international guidelines and I kind of support them generally, but it doesn't mean that there isn't a big range of what people can achieve. And also, when I think about these systems, I really think about the broad population of people, especially the ones outside of this group, this, highly educated, informed group of people. I'm thinking about the rest of the population too.
Yeah, Damiano showed us the stats of what people are across the country, and we were messaging each other saying it just feels so sad, because that's not what we're doing. I've been asked to squeeze one more question in from John Fawcett, who developed Loop Follow app, which is an amazing app that a lot of us use. What is the hard suspend BG programmed at? And he asked also something about is 110, I guess, the absolute on the target?
Yes. So 60 is the hard suspend at 60. But in many cases, it will suspend well before that. But it is a safety constraint of our system that it will always suspend when you hit below that. And yes, 110 for now. But we are looking at our data and seeing if, we can go lower. That's going to be part of next generation, algorithm work that we're doing. Actually, we're doing that right now.
Yippee. I love hearing that. There's a comment here from Maureen, but I think a lot of us feel very much the same way. Please tell her that we think she's brilliant. And we appreciate what she's done, and we can't wait to get on the Omni 5. A lot of us are saying it's a lot of work, what we're doing. And if we can come close and make life a lot easier, several of us say that would be lovely. So thank you for your time. Thank you for the work you do. We're very, very grateful for you pushing it all forward, and appreciate the time.
Yeah, thank you. I took this job because I knew that this is really revolutionary technology that I wanted to bring to many, many hundreds of thousands of patients. And, I really feel like this is probably my life's most important work. So just so grateful for everyone's support to get us here. So thank you.
Thank you so much. Yeah, you've got cheerleaders in our group, and we'll watch you very closely. And thank you so much. Have a wonderful week, and stay safe. Thank you.
Thanks, everyone.
Bye-bye.